I'm Lori Hutchison. I'm Executive Director of the Lobular Breast Cancer Alliance, and it's my pleasure to welcome everyone to today's Advocate Chat, in which we're going to hear about the results of our ILC research grantee from his population-based study and discussion of the role of the patient advocate in his research. So we're going to start with my introductions of our two presenters today, or speakers today. And then we're going to hear first from Dr. Lim about the research study results. And that will be followed by a conversation with me and Dr. Lim and Christine McKay about how it has been to work with an advocate in this study. And that should leave about a half hour at the end for questions and answers. And I just want to say, though, as the presentation is going, please feel free to write your questions in the chat. And when we get to the question and answer portion, the recording will stop. So now I'd like to introduce our speakers today. And Dr. David Lim is a surgeon scientist and assistant professor of surgery at the University of Toronto and Women's College Hospital in Toronto, Ontario, Canada. He's supported as a chair in breast cancer research, early career scientist at the Women's College Hospital Research Institute. He's also the medical director of the Henrietta Banting Breast Center at Women's College Hospital. Dr. Lim's research program focuses on improving clinical and psychosocial outcomes for women with breast cancer. He was also supported by a 2021 Conquer Cancer Young Investigator Award from Conquer Cancer, the ASCO Foundation, and the Lobular Breast Cancer Alliance. Dr. Lim completed medical school at McGill University and a residency in general surgery at the University of Alberta. During his residency, he completed a Master of Education in Health Sciences Education and a PhD in experimental surgery. He completed breast surgical oncology fellowship at the University of Toronto. He subsequently completed a postdoc research fellowship in breast cancer outcomes at Williams College Research Institute, supported by a Canadian Institutes of Health Research Fellowship. And we are very thrilled that he wanted to focus on lobular breast cancer research. Our other speaker today is Christine McKay. She trained as a social worker and worked as an addiction and mental health therapist for over 25 years with adults of all ages. Christine also provided support to client family members and caregivers. She has also completed 200 hours of yoga teacher training and restorative yoga teacher training, and is in a mindfulness stress reduction program facilitator training. Christine has facilitated groups on mindfulness and pain reduction and is published author of a book and multiple articles in the mental health field. She has done many community educational talks and presented at conferences in her professional career and has been a peer reviewer for the Journal of Mental Health and Addictions since 2003. As a breast cancer advocate, Christine is the founder and moderator of Living with Lobular Breast Cancer in Canada Facebook group, and has been a moderator on other Facebook groups, including ILC Sisters and Living with Metastatic Breast Cancer in Canada. In 2021, she became a member of the Lobular Breast Cancer Alliance's Patient Advocate Advisory Board and has participated in the outreach and research committees of LBCA's activities. She has served as a patient advocate in the development of recommendations to guide implementation planning for cancer health services and policy research in Canada, as a lobular breast cancer ambassador for the Canadian Breast Cancer Network, and as a grant reviewer with the Canadian Cancer Society. And now, without further ado, I'd like to turn it over to Dr. Lim to present the conclusion, his results, or maybe not the conclusion, the beginning of the next phase after you've completed this phase of your research.
Perfect. So thank you so much again for the opportunity. Like Lori said, I was very interested to study lobular breast cancer just because in my own practice, I see quite a bit of lobular breast cancer patients, and they often are the most challenging, and it is an understudied area. So just as an introduction, which I don't think will be news to anyone in this group, but invasive lobular cancer is the second most common type of breast cancer, but it's compared to invasive ductal, it's understudied. And it has unique biology. We also know that it behaves differently. So that has important considerations when we are working up a patient with lobular breast cancer, or even when it comes to treating them. And I could spend a whole hour itself on this second point. But as by and large, we treat patients with lobular breast cancer and invasive ductal cancer pretty much the same, other than for a few very minor differences. And in addition, there's even less is known about the significance for patients who have both mixed invasive ductal and lobular cancer. And I see these in my practice as well. So the objective of the study was to look at first incidence and survival over a 30-year period in the province of Ontario, Canada, comparing lobular breast cancer versus mixed. And then to identify the factors that are associated with survival for invasive lobular breast cancer patients. And I was interested in patient factors, tumor factors, but also the treatments that are given and received. So in order to perform this study, I utilized data that are housed at the Institute for Clinical Evaluative Sciences, Ontario. And it's an independent non-for-profit research institute that collects a wide variety of healthcare data and administrative data on the population of Ontario, Canada. And so the population is about 14 million, and it collects data on the population as well as every time that someone interacts with the healthcare system. And there's a variety of databases within ICES, and these are the kind of the pertinent ones that I used. For example, the Ontario Cancer Registry collects all cancer diagnoses in the province. It has about 96% of all the cancer diagnoses, and it includes the important staging information that we want and the types of breast cancer, when it was diagnosed. For breast cancer, we're interested in things like their receptor status. The activity level report of Cancer Care Ontario tells us about chemotherapy and radiation treatments. The registered patient database will provide information like age, where does a patient live in Ontario, and other demographic data like ethnicity and socioeconomic status is provided in the Ontario Marginalization Index database. We also have information on the types of surgeries received by looking at all the physician billing data that are in the Ontario Health Insurance Plan. And then information on the actual physicians themselves are in the ICES physician database. So there's a lot of information that's collected in these databases, and we're able to link them all using the patient. And that's how we can collect these variables and understand associations between these factors and survival. So I looked at all patients who were age 18 and over who were diagnosed with breast cancer between January 1st of 1990 and December 31st, 2020. ICD codes are just the breast cancer codes and the histologies. So we query the Ontario Cancer Registry for the ICD codes for breast cancer. And then using, again, the various linked administrative databases, I pulled the patient's age, socio-demographic factors, their tumor factors, and their treatment data. And we're able, so before I get the data, ICES does remove all the patient identifiers, so I don't know who these patients are, and that's how we can respect patient confidentiality. And then once I have this data, I'm able to calculate the incidence of breast cancer for lobular, ductal, and the mixed group over time. And I can also look at their survival and generate what we call Kaplan-Meier survival curves for the 3 subtypes and compare them. And then in order to look at factors that predict survival, we use a special type of statistical analysis called regression analysis. And that inputs all the different factors and tries to look at patterns to see if there's specific factors that are better associated with survival. And And so now we get to the results. So in the database, we found almost 200,000 invasive ductal carcinomas. There were approximately 19,000 lobulars, and these are pure lobular breast cancer cases. And then there's approximately 10,000 which were mixed ductal and lobular. The other includes other more uncommon types of breast cancer, including mucinous, tubular, or metaplastic breast cancer. And this is just another graphical representation that the lobular represented about 8% in this cohort. And then looking at crude incidence rates over time, and the comparator is the invasive ductal group, which we saw an increase between over time from 500,000 cases to approximately now 750. Now, over time, we did see an increase in lobular breast cancer cases as well, and it increased from 55 to 80 per 100,000 cases of lobular breast cancer. So we saw that it is increasing over time. Interestingly, for the mixed group, we saw that it had been increasing over time, although to a lesser volume than lobular and ductal, and then it subsequently declined, which we think is because around this time in 2000, we started testing all the breast cancer cases for E-cadherin in order to confirm whether it is lobular or not. And so that may be a reason why we're seeing decreases in mixed cases, because some of these cases prior to this point may have in fact just been ductals that look like lobular, but in fact were E-cadherin positive, so they actually were ductals. And then another way to look at how incidence rates have been changed over time is to look at the rate of change or the percent change. So the blue line is the number at risk, and that is increasing over time at about 15%. So we think that that reflects population growth and migration, but there's a net increase in the population over time at about 15%. And we see that from similar to the previous slide, the mixed group has really dropped, but over time, there is an increase in lobular breast cancer, the orange line. There is also an increase in ductal over time, but not to as great of a degree as the invasive lobular. So invasive lobular cases seem to be increasing over time, and it's greater than the amount that we think that we can explain just because of population growth and that there are more women in Ontario over time. Because the increase is much steeper than the number at risk line. Now this is a busy slide, so I'll try and break it down, but we tried to look at incidence rates for specific age groups, and they're divided in categories of 5. And we know from the literature that invasive lobulars tend to be more seen in older women, and that is reflected in the fact that you see higher incidence rates in these age groups between age 65 to 90. Although, interestingly, we do see invasive lobulars in younger patients as well, even between 45 up to 65. It's not uncommon. And interestingly, over time, we see that there's an overall trend towards an increase in almost all the age groups, especially as of late. The curves seem to be getting steeper. So for some reason, invasive lobular is increasing, not just in older women, but even in younger women, which we can't explain why exactly, but that's an interesting observation. Now moving on to the survival data. This is our survival analysis, and these are the Kaplan-Meier survival curves comparing the 3 subtypes. When we run the statistical test, there was a significance in that there is a difference in survival between the 3 subtypes. Notably, we found that the invasive ductal group and the mixed group have very similar survival. So I think part of that is because some of the mixed group, in fact, are just ductals. But more importantly, we see that invasive lobular breast cancer patients have worse survival compared to ductal and the mixed group. And this was significant. And this worse survival starts somewhere around the 10-year mark after diagnosis. Just looking at stage and tumor data, I've included it separately just because the databases aren't perfect in that they didn't all start data collection at the same time. So stage data was only collected starting around 2005. So that's why half of the cohort is missing stage data. But for the latter cohort that is available, we see that most of the invasive, now we're just looking at lobular breast cancer patients, but we see that most patients were stage 1 or stage 2 at diagnosis. 6% were stage 4 and 18% were stage 3. Looking at grade, we know from the literature that grade is not a really good assessment of lobulars. Lobulars tend to always be almost graded grade 2 by default. And that's also reflected in my data, and that's for the patients that had grade available, 72% were grade 2. And then looking at hormones receptor status, we know from the literature that most lobular breast cancers are estrogen and progesterone receptor positive. And so we see that in the database results as well. And then looking at HER2 status, invasive lobular carcinomas are rarely HER2 positive, but some are, but for the only 132 patients in this database that had HER2 data available were positive. Now, when we look at survival for stratified by stage, before we even get to that, so just looking at how stage changes over time, we see that over time, we seem to be catching invasive lobulars at a lower stage, and we're seeing less of stage 2, which is a good thing. And then looks like we're seeing slowly less diagnoses of stage 3 over time. And then when we look at survival stratified by stage, we see that there's no difference between the subtypes when we're looking at stage 1 or stage 2. But we see or stage 4, but we see that the difference again happens in the stage 3 patients, and it's somewhere around 8 years after diagnosis. Although, again, there is a limitation to this when we do the survival analysis stratified by stage like this. And again, we only have stage beginning in 2005. So one of the reasons that we don't see a survival difference yet for stage 1 and 2, maybe just because we haven't given these patients long enough follow-up time yet. It's possible that once we get up to 30-year survival for the patients that have stage data available, then we may see a difference between lobular and ductal. But even with this short follow-up period, we already see a difference that's significant for stage 3. And now we're getting into the last part, which is the regression data and trying to identify factors that are associated with better or worse survival in lobular breast cancer patients. And so first I looked at patient factors, and the first was age. And we saw that compared to the reference age group between age 50 to 54, women with increasing age was associated with worse survival. This is similar to what we see in all breast cancers, not just lobular in general. The next factor I looked at was income. And we know that socioeconomic disparities also affect breast cancer survival. And I saw a similar trend in lobular breast cancer patients as well. Women who were in the lowest quintile for income had worse overall survival compared to the reference group, who were the third income quintile. And then women who had the highest income quintile had better survival. One way to assess how healthy a patient is to look at their comorbidity index. And each comorbidity that you have, like for high blood pressure or heart disease, you get an additional value. And so the higher the score, the more unhealthy you are. And similar to breast cancer in general, we see that women with higher comorbidity scores have worse overall survival. This is looking at whether geographic location in the province affects your survival if you have lobular breast cancer. And the province of Ontario is organized into 14 local health integration networks, or LHINs. And interestingly, we found that if you were in any of these LINs or in these geographic locations, compared to Toronto, which was the reference group, you had worse survival. So this was an interesting finding that requires further exploration as to why women with lobular breast cancer in these specific regions of Ontario have worse overall survival. The next thing I looked at was tumor factors, again, for the patients that have these data available. And not surprisingly, it's very similar to the data that we see in breast cancer in general. So compared to stage 1, the higher stage you are, there's an increasing worse overall survival. Compared to grade 1, women with the highest grade, grade 3, had worse overall survival, but no difference if you were grade 2. In terms of estrogen receptor and progesterone receptor status, if you were ER, PR negative, you had worse survival. But again, there were very few ER, PR negative lobulars in general. And there was no difference when it came to HER2 status, which perhaps is not surprising since there were only 100 HER2 positive lobular breast cancer patients. Another thing I looked at was health services use. And we were able to see that in women who received mammograms in the 5 years prior to diagnosis, the more up-to-date they were in receiving their mammograms, we saw that improved or better survival, which was interesting. And it suggests that although we think that lobulars can be sneaky and they're difficult to find on mammograms, we think that if you stay up to date with your mammogram screening, you're more likely to do better nonetheless. When it comes to evaluating lobular breast cancers at diagnosis, I think many surgeons and many doctors nowadays get MRIs because conventional imaging tests like ultrasound and mammogram can underestimate the extent. And I saw over the time period that I studied a significant increase in MRI use from virtually none in the 90s to now about almost 2,500 lobular cancers do get staging MRI diagnosis, but there are still about 2,000 that don't, which calls for further study and could be something that we can do better on. But interestingly, whether they had a breast MRI or a breast or a chest MRI, women who had staging MRIs at diagnosis also had associated better overall survival. And this is an interesting finding. Although many studies have not shown that breast MRIs improve survival. So at this time, this is only an interesting finding. There are prospective studies looking into whether MRIs improve survival for sure. And hopefully, I'm hoping that they recruit enough lobular cancer patients to do a proper subgroup analysis. But this was an interesting finding. And then lastly, looking at treatment, it was interesting to see that compared to lumpectomy, the women who had mastectomies actually had worse overall survival. They did 18% higher rate of death compared to the women who had lumpectomy. And this is similar to other prior studies that have looked at breast cancers in general. And interestingly, there were 10% of the group who did not have surgery. And they had worse survival as well, but it would be interesting to see why they didn't have surgery, whether it was because of advanced age, for example. And then looking at adjuvant treatment, the women who received chemotherapy had worse overall survival. This may reflect worse stage. Again, we tend to think that lobulars don't respond as well to chemotherapy as ductals. So the ones who are more likely to get chemo are probably the ones who are higher stage and have more disease and are felt to probably benefit from chemo. And then the women who received radiation had better survival. Unfortunately, one of the limitations of this database is that we don't have information on endocrine therapy like tamoxifen and letrozole. So putting it all together, we did find some interesting findings. We found that the incidence rates of lobular cancer and ductal are increasing, while that of mixed are decreasing. And lobular and ductal are increasing greater than the population rate of change, which is interesting. And because we're expecting an aging population, and we are seeing an increased incidence in most age groups. We expect that the overall burden of invasive lobular cancer will increase over time, that we're going to see more patients with lobular breast cancer. Interestingly, we saw that survival is worse after 10 years for lobular breast cancer compared to ductal and mixed. Again, further underlying a need for better research and better treatments for lobular breast cancer. Again, by and large, they're pretty much treated the same at the moment, and they receive the same surgical treatments and medical treatments and radiation. And then we also saw various patient, tumor, and treatment factors that are associated with overall survival. Some of these we can't change, like patient age, but other things, it was interesting to see that MRI was associated with better survival. Having a lumpectomy was not any worse, or was actually better than mastectomy, which requires further study. But some of these things were interesting findings that I think provide important information to patients. There are some strengths and limitations. This is a large database, and it captures 96% of all the cancer diagnoses, so it's pretty comprehensive. But there are limitations in that some of the stage data was not available prior to 2005. We don't have endocrine therapy, and it is retrospective. But in summary, then, we think that based off of this data, we think that the overall burden of lobular cancer is going to continue to increase because of an aging population, and it's increasing in most age groups. Lobular breast cancer does have worse survival beginning at 10 years after diagnosis, highlighting a need for further treatment. And there are various factors that are associated with worse or better survival, some of which we can control and some of which we can't. And these are all points for future study and highlighting to patients and improving patient education. I did add one comment here about the role of the patient advocate. So I want to thank the Lobular Breast Cancer Alliance again for this opportunity. They were actually the ones that connected me with Christine in working with a patient advocate in developing the proposal for this initial proposal for this study. And so we met prior to the proposal to discuss the research plan. We bounced ideas off each other. She actually raised important elements that were worth investigating, and some were not available. I know Christine is very interested in learning more about recurrence as well, so that's something to be seen, whether I can assess recurrence using the ISIS data. And I think that's it for my part.
Thank you so much. And before we get into, there's many questions in the chat for you about these findings and your discussion. I want to move to our conversation with Christine and you together about your experience working together for the first time, perhaps Dr. Lim with patient advocate. Christine, you may have had more experience. And I guess I'd like to start, Christine, hearing from you about how this was for you. And then we'll go back to just a dialogue between the two of you about the process and what you would suggest, because this is something that we require of any ILC research grantees through LBCA, but we always want to make it a better process for everyone involved, as good as it can be. And we're also building a registry of people to become patient advocates for researchers. But so all of your thoughts and input will be helpful. But Christine, why don't we hear from you about how this went?
I didn't feel like I was asking any stupid questions. Dr. Lim made sure that all questions were entertained, and I was impressed mostly with his wide range of background, plus his education masters, which to me indicated desire to be able to communicate medical data and information. Some of the initial work together took place during the pandemic, and I wasn't able to sign my one-page recommendation because Staples was closed and I couldn't fax it. So there were little things like that that were at play during that time. The most intensive time of work was when the project was being formulated, and that had quite a quick turnaround. But then it slowed down after that. I'm really looking forward to seeing the total picture when it's published, because I find that I have questions now that arise from the data. So he's been great to work with, and I couldn't ask for a better mentee.
And I have a question. David, are you working with Christine on developing the manuscript? So she'll have an opportunity to maybe talk with you about some of your findings before you finish your write-up?
Correct. So that's part, as I'm writing up, it's again, what's in here is probably too much for one paper. There's probably going to be one paper looking at incidence and the patterns of incidence, and another paper looking at survival and the factors associated with survival. But Christine will definitely have be a part of that too, and I'm interested to see her thoughts, because in the discussion, I think that's where a lot of the thoughts go into, and it's a springboard for the next steps. This was kind of, I started working with two patient advocates at the same time, and this is kind of happening all together. So it was really my first time working with patient advocates, and I think it was a very valuable experience. Often we're so focused on the scientific aspects, we forget about the human side of things, and I really think that that's what Christine really offered, especially having gone through her experience. You know, there were a lot of points that she contributed to. She had questions about, you know, recurrence, about different endocrine therapies, and you know, when we were formulating the research, you know, we would discuss some of the limitations of the data, that some things are just not available, and I think that will spark future research into finding ways then how to get that kind of data, like endocrine therapy and things like that. But I think it was a very valuable experience. I've learned a lot, I think, from working with patient advocates, and I've also learned a lot about patient advocates themselves. I think they make an important contribution, and they're somewhat undervalued as well. So one aspect I think is also finding a happy medium, so that I didn't you know, overstep the boundaries and make her work too much. So that will be a learning point for me going forward, because I think patient advocates are an important part of the research team, and they do contribute important time and efforts and hours that I think I think when I apply for grants and research funding, I will probably set aside a column for remuneration for the patient advocates. Mm-hmm.
That's fantastic.
Yeah.
Any other thoughts you or Christine would like to share about how the process was for you before we move on to questions? No? Okay.